Bobby Hudson.
Good morning, everyone. I'm going to present on the title Hump of a Lump on behalf of Medicine 1. Coming to Mr. A, 25-year-old CNC staff working in the hematology department as a nursing faculty, has presented with complaints of throat discomfort, cough, which is non-productive in nature, and body ache for the past 4 days. He then started developing fever, which was low-grade fever initially on day 1, which was intermittent, and then on day 2, he developed a high-grade fever again, which was intermittent, and he also developed a rash on day 2, which was intense, with intense itching over the face. He also noticed that he was passing high-colored urine on day 2, and then he has come to CMC Velu for further evaluation and management. Coming to the negative history, there was no history of any abdominal pain, distension. There is no history of any breathlessness. Past history was there is no history of any high-risk sexual behavior. Coming to the relevant past history of a visit to a nearby pool 1 day prior to the onset of symptoms was present. And for the coming to the drug history, the only drug that he has used prior to during the symptom period was only paracetamol for the control of the fever and the body ache that he has presented. Coming to the family history, there is no history of any similar complaints in any other members of the family. Coming to the vaccination history, he received all vaccines according to the vaccination schedule in the Chad Bagayam. He also was vaccinated for the COVID infection. On examination, his pulse rate was 120, which was regular. His temperature was 101 degrees Fahrenheit at the time of presentation, and he was having icterus on examination. He also had a right-sided post-occipital region 1 into 1 centimeter sperm, non-tender lymph node, and an erythematous rash over the face. However, there was no eschar present on examination. On examining the oral cavity, tiny lesions were present over the bilateral buccal mucosa involving the palate also. Systemic examination was, however, normal. Coming to the clinical syndrome, 25-year-old young man who was presented with acute febrile illness with rash.
Describe the rash a little bit more.
It's a maculopapular rash with an erythematous base. Based on the clinical syndrome of fever and an maculopapular erythematous rash, our initial diagnosis was a rickettsial spotted fever, since he had a recent history of a visit to a pole situated nearby a forest area. And the other second differential was infectious mononucleosis. However, we considered measles as a third differential diagnosis because he was already vaccinated for the disease. On further initial evaluation, he was found to have an abnormal liver function test with a total bilirubin of 3.3 and a direct bilirubin of 3. But however, the blood cultures were negative, and spotted fever, scrub typhus, and dengue was also negative. In further course in the ward, he was on the day 2 of admission. There was a spread of the rash from the face to the upper limb and the lower limb, and it was a maculopapular rash, and the rash was associated with intense itching. However, the palms and the soles are spared, and then measles was again suspected, and we examined his oral cavity again and realized the initial examination finding was none other than Koplik spots. Hence, measles was strongly suspected, and we sent a anti-measles IgG and IgM titers, which was positive for a measles. However, the skin biopsy was also sent, which was showing features of viral exanthem. Coming to the measles, measles is a very rapidly contagious viral disease, and the common presentation of the virals, classical measles is usually a prodrome containing of a fever, followed by rash and Koplik spots at the same time, also associated with conjunctivitis. But we are more interested in our patient because our patient is already vaccinated. So I would just like to introduce the term modified measles. Modified measles is measles which is occurring in a patients who are already underwent immunity either through a prior measles infection or a prior vaccination. So what are we interested in these patients, and what did we wanted to learn is what is the incidence of modified measles and why does it occur? What is the reason for the occurrence of modified measles, and who are more prone to develop modified measles, and how do they present clinically? And what are the chances of transmission of measles from such individuals, and whether we should consider giving a booster dose or a catch-up vaccination in such individuals. Coming to the evidence, this is a study done in California from the year 2000 and 2015, where 232 cases of measles were studied, and out of which 11% had history of receiving measles of more than 2 doses of vaccine. Coming to the second question, why does measles occur in individuals who are already vaccinated? This is a systematic review. One of the reasons it was telling was where the study concluded that the antibodies or the vaccination that they have received started to wane off after a period of 10 to 15 years, which is usually seen in less than 5% of the individuals who are vaccinated for measles. This is one of the main reason for the occurrence of modified measles. So this is nothing but a vaccination failure also. The main thing depends on the duration of the protection. Such candidates have a variable protection from the measles, and which is very shorter. As we have discussed earlier, the further studies also concluded that the 5% patients lose the protective antibody titers after 10 to 15 years of the second dose of the vaccination. Also, the other theory that was postulated based on the studies was areas or the regions where there's a low vaccination rate but a higher measles incidence usually have a lower breakthrough incidence. Breakthrough is nothing but the incidence of again a modified measles. Whereas where countries or the regions which are having higher vaccination rate and the incidence of measles is less, these are the areas or the places where the occurrence of a modified measles is very high, because already the people, most of the people are vaccinated, and there is very less virus available among the non-vaccinated people. So the people who are actually vaccinated are not fully immune to the virus, and these are the people who are going to develop a modified measles infection. Coming to the type of vaccine failure, we can divide it into primary vaccine failure and the secondary vaccination failure. Primary vaccine failure is usually a complete absence of a measurable immune response. These people are also called as non-responders. Coming to the secondary vaccination failure, these individuals have a immunization prior, but they don't have a complete response of the immunity against the vaccine disease. As you can see in this picture, this line represents the protective antibody level. When the first dose is given, usually we'll see a rise in an IgG antibodies, and when the second dose is given, there should be further boost of the immune response. However, in patients with primary vaccine failure or non-responder, as we can see, there's no protective level of antibodies or immune response seen at all. Whereas in patients with secondary vaccine failure, you'll see a rise in the IgG antibodies or the immune levels after the first dose and the second dose. But however, these antibodies or the seropositive rate fall down after a certain point of time. In immunized people, these levels are always above the protective level. So how do we identify such people when they present to us? As you can see here, people, we can clinically define the patients based on their clinical symptoms and the serological positivity. As we can see here, if the patient doesn't have a measles infection, there's no IgM or the virus in the individual at all. So there's no chance of any acute infection in such patients. Whereas patients who are presented with measles, there are again two possibilities because a patient who have a late infection or an acute infection, we can see IgG or an IgM antibodies. But as the infection goes off, that is during the late infective period, that is more than 10 days after the acute infection, the IgG levels come down in these patients. Whereas in patients who are non-responders, there you can see IgM levels and virus presence, but you cannot see IgG levels because they are unable to mount a response. This is called the non-responders or a primary vaccination failure, like how we have discussed earlier. Whereas in the secondary failure, the IgG levels will be very high, and IgM and IgM presence is also noted in them. This is a further study which was done in Spain from the year 2014 to 2020, where 998 individuals were studied, and we noted that most of the individuals who, especially the healthcare individuals who developed measles, were more who actually took 2 doses of vaccination for measles, as you can see in this picture. This graph represents the occurrence of the modified measles in such individual, where the total occurrence is 31.5%, and people who did not take vaccination but who has got a prior measles infection, they developed only 21% of them developed measles, modified measles, whereas people who took 2 doses of vaccination but developed a secondary vaccination failure was the highest among this modified measles population. So who are more prone to develop? Among the health workers. Again, the same study has described that the nursing people who healthcare workers who are actually spending a lot of time with the patients, especially the sick patients in the ward, are more prone to develop modified measles. So among them, the registered nurses are actually more prone to develop modified measles than the doctors. So how do they present? The typical measles usually presents with a rash which starts in the face and then goes down from the hairline, involving the upper limb and the lower limb and the trunk, but sparing the palms and the soles. But modified measles patients may not present like this, and the presentation, since they already have a little bit of immune response, the presentation usually varies. They can have complex spots or not. Even the rash also can start in the trunk, and then it can involve the face. Sometimes it may spare the face also. So and it becomes very difficult to diagnose in such kind of patients. Coming to the next question, what are the chances of transmission of measles from these modified measles infected patients to other population who are non-infected? Among the study, which was again done in Portuguese from in the year of May 2017, from February to May, this study concluded that though the modified measles patients are infected, but the chances of transmission from these patients to other individuals is very less. In fact, there was actually a case report where one of the sister in a hospital has actually was infected with measles due to secondary vaccination failure. She was traced, and she was the number of individuals that she was actually involved with the patients and the doctors were traced, and it was found that 71 of the healthcare workers and 195 patients were actually interacted with the patient during her incubation period and her infectivity period also. And those individuals were followed for the next 3 weeks for the incubation, during the incubation period of the measles, and it was found that only some 13 of the patients out of the 195 developed the infection, and more than 55% of the patients have not developed the infection. So should we consider giving the booster dose or a catch-up immunization for such individuals? Before talking about the modified measles infected patients, we should definitely give a catch-up vaccination for all the individuals who have not received the either the first dose or the second dose of a measles vaccine. And also the secondary vaccination failure, like modified measles patients, they cannot have the completely eradicate the infection immediately, but they can develop a rapid neutralizing response that is helping them to develop only a mild disease but preventing the complications. So we can actually need not aggressively go ahead and give a booster dose or a catch-up vaccine for such patients. If we want, we can actually do a IgG titers in such patients and then decide whether we can give a booster dose. Coming to the management in our patient, we manage him conservatively, and within 4 days after 5 days after the admission, his fever has come down, his liver enzymes and his rash has also settled down. Also, since measles is a notifiable disease, the health authorities, government authorities were notified, and they also took his vaccination history, and they have examined him and took the samples from him for the measles also. And all the health staff who actually took care of him have been asked about their vaccination status, and they have been advised to immediately follow up if they have developed any such symptoms. Learning points, the occurrence of modified measles and the vaccination failure in measles and how to manage such patients.
Thank you, Bobby, for the nice presentation. Any questions?
If you ask about the detailed MMR vaccination history, how old is he? He's 25.
25, sir.
So, how many doses has he taken?
He has taken 2 doses, sir.
Child.
Yes, sir, child, yes, sir.
Then, did you take the one preschool?
That they did not have the.
And the booster at the adolescent, as an adolescent?
No, sir.
It's not taken. So, so he has taken 2 childhood.
Yes, sir.
So, what is the incidence of vaccine failure in such individuals? One of your studies had a denominator. So, how often does this happen?
1 in 10,000, sir. 1 in 10,000 is
1 in 10,000. The question is about the rash. How often does I thought the classical teaching that viral exanthem, the rash is non-itchy. He said it was an intensely pruritic rash. Is that correct? He said it was a pruritic rash.
Yes, sir.
How often does that happen? This disease is pruritic or non-pruritic?
It is pruritic. I'll check 1 second.
And his IgG titers were very high.
Yes, sir.
Even then, he had a breakthrough infection. So, the diagnosis of measles, confirmation. What is the confirmation based on?
Based on the serum test, sir. And the clinical picture, sparing the rash, typically sparing the palms and the soles.
Did you ask our colleagues in pediatrics how does this happen? How do they see?
They have seen last week alone. They have seen some 5 cases, sir.
The children who have been fully vaccinated.
Yes, sir. And I have asked the history of this young individual. Apparently, one of the registrar in hematology also had measles infection, and we also spoke with the ID regarding this. They were also saying they had actually 2 registrars from hematology who got infected with measles, and probably from there was it transmitted to him. But I asked him whether he got into contact with other individuals. He was saying no.
It's a very highly infectious most infectious form of
few things comes in is what is the role of boosters? How much does that bring down? And the other thing is in the adults, what's the whether the antibody levels is a reflection of their protection? How does that vary with age to justify adult immunizations with the boosters? And what are the
UIP recommends only 2 doses at childhood. The adolescents, UIP, no adolescents come to UIP, but the ASIP recommends 1 more booster at adolescent, I think 15 or something. After that, no boosters are recommended, no routine vaccines for the. Did you read it?
Yes, sir. No boosters are usually required for even such
individuals. So it's so good. My question was that it's an extremely good vaccine. Obviously.
So all the other people who got it were also immunized.
Immunized, yes, sir.
You saw the chart, immunization chart,
Yes, sir.
and it was vaccinated.
The other two were, yes, sir, doctors who were vaccinated.
There is a surveillance which is going on. Fever with rash surveillance by ICMR. So I think more Indian data will be coming.
He works in hematology department.
Yes, sir.
We did go to the department. My God. For them, it will be a disaster.
Give no compromise picture. The government officials are notified.
Yes, sir, they were notified. They actually conducted a camp.
They have taken the sample.
Yes, sir.
So did he transmit to others? That's the other thing to think about. If he got it and others didn't get it, if they were in close contact, so what is it that made him get it? Most of them would have been immunized, but then some people are getting it. Also to think about as to what would be the most issue, response to that. I'm not sure. Something to
Okay, thank you.